Yeah, I will be 5 minutes.
Yeah. Okay. So
So hopefully,
before I start the program formally, how it will go is I will just welcome everyone, introduce our chairpersons for today, and then the chairpersons will take over, and of course they will handle the program as it goes, including the Q&A. And in the end, Priyanka will just give the vote of thanks. So that's that. Good evening, everyone. As the president of Bombay Psychiatric Society and my secretary here, Priyanka, and the entire EC and the entire team, I welcome all of you for today evening's event, which is on the interface between PCOD and psychiatry. To today, is probably one of the times where we have an all-women's panel, as mentioned by one of our chairpersons. So both our chairpersons are ladies, extremely intelligent, gracious consultant psychiatrists themselves. And of course, all our three speakers are ladies. I have been told I'm the odd one out. So I will only introduce you all and then go off so that I'm not the odd one here. But anyway, the whole emphasis of today was we wanted people to know about PCOD. We wanted people to know about PCOD and psychiatry. That's why we decided to have this. And we're very happy that we'll also get a dermatological angle, which will give us some added information about this. To introduce our chairpersons, we have two extremely talented chairpersons. Our first chairperson is Dr. Sarmishta Chakrabarti, who's a senior consultant psychiatrist at the Columbia Asia Hospital in Kolkata. She's also working with the Ramakrishna Mission Seva Pratishthan Hospital. She runs the Insight clinic at Bollygunge in Calcutta. She's currently the chairperson of the Indian Psychiatric Society Women's Mental Health Specialty Section, with whom we are partnering to do this, along with the Indian Association of Private Psychiatry Women's Mental Health Section. Madam has been a face at numerous national and international conferences. Madam has also represented West Bengal in the East Zone as a direct council member to the East Zone. And Madam is actively, of course, participating in many seminars, and she's also been a part of women's mental health very actively. So, Madam, it's an absolute pleasure to have you here. Our second
thank you
chairperson.
so much.
Thank you, ma'am. Our second chairperson for today is Dr. Hina Merchant Pandit. She is an associate professor at the Department of Psychiatry, Lokmanya Tilak Municipal Medical College. She has also been part of many publications nationally and internationally and done a lot of research work. Hina and I personally, we go back right to our residency days. We've done our residency together, and from then to now, it's been 22 years. It's the month of August. She's also a Rakhi sister to me since then. So I had to have her in this month here in this program. So though she forgets whenever Raksha Bandhan is, and I have to remind her, but that's still fine. So anyway, welcome to both of you all. And I will now hand over to Hina and Sarmishta Madam to carry over proceedings.
Good evening, one and all. Thank you, Avinash. At the outset, I would like to thank the entire Bombay Psychiatric Society and Avinash once again for having me here as a chairperson for this very pertinent topic, as you highlighted earlier, which is the PCOD psychiatry connection. As we are all aware that PCOD is accompanied by an array of symptoms. Physical ones being those of obesity, acne, scalp hair thinning, menstrual irregularities, subfertility, and it also manifests with psychiatric disorders such as those of depression, anxiety, mood dysregulation, borderline personality disorders, disorders of eating, poor self-esteem, and psychosexual dysfunctions. And to share today with us, we have three eminent speakers. It gives me immense pleasure to introduce the first speaker of the day, that is Dr. Sejal Ajmera. Dr. Sejal Ajmera is a consultant obstetrician and gynecologist. She is the founder of the Indian Academy of Vaginal Aesthetics. She's done her fellowship in Advanced Masters Surgical Preceptorship in Aesthetic Vulvovaginal Surgery. She's also done her Cosmetic Gynecology Cadaveric course from the International Society of Cosmeto-Gyno 2019. She has done her fellowship in endoscopy from France, Singapore, and has also done her fellowship in IVF from Mumbai. She has many awards to her credit and has also received the Best Speaker and the Best Gynecologic Award in the year 2011. She has also featured on the Forbes India and BBC London. She is currently a practicing obstetrician and gynecologist at Juhu, Santa Cruz, Surya Group of Hospitals, and NMC Hospital at Dubai. Our second speaker for today is Dr. Sama Reis. She is the founder of Derma Hub, a clinical and cosmetic dermatologist with a fellowship in lasers and dermatosurgery from Singapore. She has over a decade of experience with several clinics and hospitals all across Mumbai, ranging from government hospitals to corporate setups, including the Kokilaben Ambani Hospital, where she has worked as a full-time consultant. She has authored many chapters in the Indian textbooks of dermatology and in cosmetic dermatology. I welcome you both, and I request my co-chairperson, Dr. Sharmishta Chakravarti Madam, to kindly introduce our third speaker, that is Dr. Rukshida Saida.
Thank you so much, Hina. I thank Bombay Psychiatric Society because we from Indian Psychiatric Society Women and Mental Health Specialty Section, we've been thinking about this topic for a very, very long time. And it's a pleasure to liaise with Bombay Psychiatric Society and IAPP. And, you know, what a wonderful day to actually talk about PCOS and the mental health issues related to it. Because we all see it every day in our mental health clinic. And sometimes, you know, there is a huge, we don't know whether we always consult the gynecologist as well, because it's a liaison psychiatry when it comes to PCOS and mental health problems. Now, what better it is for me to introduce Rukshida, because I've known Rukshida, you know, very, very closely over the last 2 years, because we've been co-chairpersons of the Women's Specialty Section of Indian Psychiatric Society. And I am not looking into anything when I'm introducing her, because she, you know, what I know about her is she's an extremely dynamic lady, a very respectable one. And she has 2 TED Talks, and I've listened to them, and so many times I've asked my patients to listen to them about abuse, childhood sexual abuse, and women mental health. And she's been advocate for a very, very long time. I think she has 18 to 20 years of experience in psychiatry, and she specializes in psychotherapeutic inputs. She also has become the Indian Association of Biological Psychiatry. She heads it. And, you know, there's so many things. I call her celebrity, because I think she's done so much of work with Bollywood as well and mental health issues that whenever I need any help with Bollywood, I ask Rukshida. So it's such a pleasure to introduce Rukshida. I'm really, really very happy and eager to listen to all the speakers today. Thank you so much. So, shall we start with the first speaker?
Yes. So may I please request Dr. Sejal Ajmera?
A very, very good evening, and really, really happy to be here today for the all women's panel, especially. But thank you, Bombay Psychiatric Society. Really happy to be here today, especially so because I'm talking with 2 of my closest friends, Dr. Rukshida and Dr. Sama. So, you know, you can see me all beaming and really, really happy about it. So thank you for having me here. It's absolutely my pleasure. PCOS is something that, you know, we are all seeing so much of. I'm going to start, you know, sharing my screen right away. And very happy to talk about it because like we rightfully said, you know, it is a liaison between a dermatologist, a psychiatrist, and a gynecologist. So let's start right away. Sorry, I'm not able to. Okay. All right, so let's talk about the polycystic ovarian syndrome. A question very often asked by a layman or a doctor sometimes, that is there any difference between the PCOS, the PCOD, or the metabolic syndrome? Well, really not, and they all mean the same thing. It is one of the commonest endocrinopathies in women who are at a reproductive age and is associated with metabolic disorder and reproductive dysfunction. The prevalence is high and it ranges from 6.5 to 20% depending on the criteria. But I think all of us know that in our OPDs, it's one of the commonest things we see. I think I may be seeing 5 new girls with PCOS every day. Well, it is a lifestyle disorder, which makes it really, really hard to treat. It is associated with the stress and the junk food that the youth eat today. There is a genetic predisposition from mother to child, and undoubtedly, it is very, very common. A lot of people feel that PCOS is a defect in the ovary, and it really takes a lot of explanation to get that it is a defect in the hypothalamic pituitary axis, insulin secretion, and hence there is an ovarian dysfunction. So there is increased LH and GnRH. However, the FSH is muted or unchanged. There is decreased SHBG, and this is what increases the free testosterone, which gives us a lot of the symptoms of PCOS. And the thecal cells by themselves release testosterone and 17-OHP. This is the role of hormones in the menstrual cycle. Well, this condition should invite early diagnosis, and I think this is why we are here, because there's a considerable evidence that women with PCOS are at a higher risk of infertility, dysfunctional uterine bleeding, metabolic syndrome, type 2 diabetes, which is more than 50%, cardiovascular risks, sleep apnea, hypertension, dyslipidemia, anxiety, depression, fatty liver, endometrial cancers, and even PMDD. What are the commonest symptoms the patients present with? So common rate is irregular periods, absent periods, infrequent periods. However, you must note that sometimes they come with frequent menstrual periods also. Hirsutism, acne or oily skin, male pattern baldness with thinning of hair, obesity and weight gain, especially around the waist. We see more than 12 cysts in one ovary on an ultrasound appearance. However, like we tell all the patients, these are not actually cysts, they are the own eggs. I think this word cyst is what really scares a lot of our patients. We can get skin tags, underarms or around the neck. Acanthosis nigrans are dark pigmented patches in the areas of nape of the neck, inner thighs and arms. And of course, sometimes they come to us when they find it difficult to get pregnant. Well, the diagnosis has clinical criteria, biochemical criteria, and ultrasound. Most of the patients just come with an ultrasound report and the doctor says, okay, you have PCOS, let me treat you. Please let us establish the biochemical criteria before we embark on treatment, because the treatment changes the hormones and then we can never really find out where the original markers stand. So in the clinical markers, we have menstrual irregularities. Like I said, oligo and amenorrhea is the commonest, but how do you define it? It is less than 8 cycles in a year. We get signs of androgen excess, which is hirsutism, and the score of more than 8 on the Ferryman-Galloway index. And of course, obesity is really, really common, though occasionally we do deal with lean PCOS also. The biochemical markers are hyperandrogenism and insulin resistance. So we do the blood test for both. On ultrasound, if we see more than 12 antral follicles, which are 2 to 9 millimeters in either ovary, and an ovarian volume of 10 ml. So this is one thing I want to tell you, that preferably when you're telling a patient to get an ultrasound done, let's do it during the first few days of their periods, and ask the sonologist particularly to measure ovarian volume, because that is not routinely done. We see a lot of patients at puberty, and sometimes there's an overlap. And I think diagnosis at puberty is very, very important, because at puberty, the first 1.5 years, the patient could have anovulatory cycles, and the ovarian appearance on ultrasound is confusing. Hence, always look for clinical and biochemical hyperandrogenism, especially when we are dealing with problems at puberty. I am not going to go through the criteria for diagnosis, but it is still not well defined. By and large, we have all the criteria, which say 2 of the 3 criteria are enough for the diagnosis of PCOS. But you have the NIH in 1990, the Rotterdam criteria, the ESHRI consensus, the Androgen Excess Society. They all basically say that it's ovarian hyperandrogenism, ovarian dysfunction, the polycystic ovarian morphology on sonographies, or 2 of the 3. Remember one thing, we need to exclude other androgen disorders of excess. Do not presume that any patient who has hyperandrogenism is only PCOS. So let's rule out congenital adrenal hyperplasia, Cushing's, tumors, a higher prolactin and thyroid disorder, which is very, very commonly seen with PCOS and which does worsen the symptoms. So in November 2015, again, the criteria were revised, and it came as 2 out of 3 if you have chronic anovulation, hyperandrogenism, which could be clinical or biochemical, and PCOS. So this is the diagnosis and causes of it. Let us talk about insulin resistance. I think this is really, really important because 50 to 80% of the women with PCOS are obese, and we go to a vicious cycle of insulin resistance. Why is that important? It is insulin that drives the glucose inside the cells for metabolism. With PCOS, all the receptors that we have do not let insulin push the glucose inside, which leads to hyperinsulinemia, and it leads to diabetes. The more the insulin resistance, the more the weight gain, the more the weight gain, the more the insulin resistance. And we have to break this cycle of insulin resistance with the diet and exercise programs that we do suggest for the girls. And this is the only probably natural way of controlling PCOS, and that is having a good diet and exercise cycle and controlling the weight. So, well, these are the investigations we usually do. And I think this slide is really, really important because when the patient comes to us, we've realized that she has done only a few tests, one ultrasound which says PCOS, and then they are put on hormones or something or the other, and we lose the baseline hormones, or sometimes even the diagnosis where we miss other causes of hyperandrogenism. So there's a huge list of tests we do, and this we do explain to the patient at length. Remember, the tests are still preferred to do during the periods, fasting. We do the entire gamut of gynec hormones, thyroid, prolactin, testosterone, dihydrotestosterone, free testosterone, vitamin D, lipid profile, insulin markers, AMH, and others. So I think our detailed investigations for PCOS are very, very important, and we do try to do this in all our patients. Whenever the fasting insulin is 8 to 14, it suggests mild insulin resistance. And of course, today we can do the HOMA insulin resistance test. If it is more than 3, it suggests severe resistance. These are simple ways of finding out insulin resistance. We know the signs of androgen excess, which is hirsutism and acne. And if the patient is unaffording and we have to do few tests, then free testosterone is the most sensitive test for hyperandrogenism. 15 to 40% of women with hyperandrogenism and regular periods do have ovulatory dysfunction. This is important to note because we feel that, okay, we do not need to treat the patients, but they could have ovulatory dysfunction even if the periods are normal. And you must rule out non-classical congenital adrenal hyperplasia. Well, long-term effects is something we all are aware of. They come to us with subfertility. So whenever a young girl has PCOS, she's getting married, we do tell her that do plan your pregnancy a little early. It is one of the most treatable causes of infertility. All they need to do is usually require some medication with weight loss and exercise. And the results for PCOS for infertility are very, very good. I think this is one condition which not many people are aware of, that when you have PCOS, you have higher chances of endometrial cancer. Why is this? Well, most of the patients, especially when they're in the 30s and 40s, are ignoring the fact that the periods do not come every month. They come to us very happily saying, Doc, I'm so lucky this entire year. I had only 4 period cycles. How happy can I be? Well, I think that is the problem because in these 4 cycles, you've hardly bled out the endometrial lining, and we have a much higher chance of endometrial cancer. So what I tell the patients is taking the medicines is 10,000 times safer than waiting for them to occur naturally, because that is what they do. The risk of endometrial cancer is 2.7 times higher, and a lifetime risk is of about 9%. There is a higher risk of hypertension. So we do a lipid profile every 2 years. A risk of diabetes. Already 36% of them have an abnormal glucose tolerance. They have a 5 to 10-fold higher increase of diabetes, and hence a OGTT every 5 years is advised. And of course, they could have obstructive sleep apnea, which really hampers their sleep and causes insomnia. And we need to look into this with weight loss. Does PCOS have anything to do with pregnancy? Absolutely, it does. It increases the chances of miscarriage, increases the chances of gestational diabetes, pregnancy-induced hypertension, and preterm. One thing, a lot of girls have been put on metformin, which is the anti-diabetic drug for PCOS. We must continue it during the pregnancy so that it doesn't increase the chance of miscarriage. Let's come to the treatment. I think we need to reiterate to the patient that there is no cure, because usually they go from one doctor to another thinking that it's the doctor's fault, and every time I stop the medications, it comes back. But this really needs to be explained to them well, that it's a lifestyle disorder. The only natural way of controlling it is to have an ideal weight. When we are talking about diet, we tell them to have small, frequent meals. Breakfast should be the heaviest meal of the day. Dinner should be the lightest meal of the day. I think what is the problem is carbohydrates and sugars. So we ask them to convert to at least having no carbs for dinner, decrease their sugar intake, and convert to carbohydrates which have a low glycemic index. Well, what does that mean? Well, instead of potato, have sweet potato. Maybe instead of sugar, have jaggery. Instead of white rice, have brown rice. So make a significant change in your diet where you decrease the carbohydrate and the white sugars and foods of a higher glycemic index. When we are looking at weight loss, dinner should be totally carbohydrate free, should be had preferably by 7:30 p.m. and nothing till 7:30 a.m. the next day. Exercise is as important as diet, and the role of exercise is very well established for PCOS now. Irrespective of the weight of the patient, they have to have exercise. What we say is high impact activity, 3 times a week, which is 1.5 hours of high impact exercise, is important, which means that thrice a week they have to do something like aerobic, Zumba, running, skipping, jogging, because high impact activity is very important. The other 3 days too, they have to exercise, but it can be walking, yoga, or whatever they like. So essentially what we are saying is exercise should be a part of daily routine, and 6 days a week we should exercise. And that is one very, very good way to beat PCOS. Let's talk about the medical basket. I think the oral contraceptive pills form the mainstay of treatment. Obviously, it is a hypothalamic pituitary disorder, and the oral contraceptive pills give you the hormones at the correct concentration. Remember, they never give you weight gain. We have zero weight gain pills today. A lot of girls who have hirsutism, we start on anti-androgen pills. Remember, they have to be taken for a longer time. I tell the patient, if you're going to be taking this for 3 months and 4 months, it is no use at all. You have to take it for 9 months to a year to see the anti-androgenic effects, and this is important. Counseling for the oral contraceptive pill is again very, very important. Otherwise, she's going to stop it because everybody's going to tell her that you can't take it. Of course, for those who have hirsutism, androgen receptor blockers like flutamide, spironolactone, finasteride do form an important part of the management. One of the commonest things we use today is metformin. Remember, it is a diabetic drug, but we do not wait for the patient to get diabetes. If she has insulin resistance, she's not able to lose weight, pregnancy is what she's looking at, metformin works really, really well. Today, for a lot of people, tolerance to metformin is really, really hard. And then we can start them on myoinositol, D-chiroinositol combinations. Girls who have lean PCOS and not obese PCOS do very well with this. Remember, vitamin D levels have to be checked and treated. Of course, those who come to us for fertility, the fertility drugs is what we give them. Remember, there's absolutely no role of surgery for the treatment of PCOS. The only time we do surgery is when the patient desires a pregnancy, she's not getting pregnant. We are doing a laparoscopy for other causes of infertility, and we do PCOS drilling of both the ovaries. This temporarily restores the ovarian function better, ups their chances of pregnancy, but eventually it comes back again. So this is some of our papers on it. And thank you very much. If you have any questions, I think after the speakers talk, I would love to take them. This is a very, our Instagram handle, which a lot of girls like. I'm just mentioning it here because it's called at Once Upon a Vagina. And we do cover topics like menses, PCOS, and a lot of things. And for the layman, they find it really, really exciting to go through this. So thank you. Thank you very much.
Thank you, Dr. Sejal and Mera. How fantastic, how simple, and you stuck to the time, and excellent presentation. What can I say? It was very useful. It was so brief and useful. Excellent. I think one red flag has been endometrial CA. You know, people take PCOS very, people who suffer from it, the young people especially, they take it very like, a lifestyle disease, and it will go just like that. And I'm on OCPs, and they go to, lots of other kind of treatment. But I think it's so important to understand that it can be converted to something pretty dangerous. So yes, It is lifestyle. Obesity is one of the things, but there are so many lean PCOS as well.
Yes.
You're right. Okay. Thank you. Hina,
Thank you very much.
Yes. Thank you. Thank you. Hina, anything from your?
I will now request our second speaker for the day, Dr. Sama Reis, to kindly enlighten us regarding the surgical as well as the cosmetic aspects of PCOD.
Good evening, everyone. It's an absolute pleasure to be here. I think, like Sejal mentioned, yes, we have been closely associated and we have worked on a lot of PCOS patients, also Rukshada and Sejal and me together. So it's an absolute pleasure to be here today. And of course, Rukshada has always been my go-to person for all patients that I've had challenges with. So I'm trying to quickly put across my challenges with what we call psychodermatology as a dermatologist, and of course the patients that I see in clinical practice and the challenges and how we can get them to see psychiatrists or psychologists. In my very early, in fact, I've always had a keen interest in psychology and have always read for personal interest. So much so that I remember, I think in internship, I may have probably been the only intern who actually read the psychiatry textbook. So when I went ahead and did dermatology, and like most of you would know, there is a field specifically called a psychodermatology, which deals with a lot of neurocutaneous disorders. So in my early days of practice, I was always very proud to have diagnosed an underlying OCD in a patient with maybe acne excori, and I consider myself to be a very empathetic doctor. And very, very confidently and proudly, I would tell the patient, see, I think you need to see a psychiatrist. Very soon I realized this wasn't working because most of them didn't land up seeing a psychiatrist. So I kind of improvised this attempt, and then I started putting in a little extra time, hoping I could create some insight and maybe make them conscious of the issues. But then soon I realized that this was not working for me because I couldn't be sitting with 40 minutes every patient, 20 minutes of dermatology and 20 minutes of counseling. So definitely the question that has plagued me for a very long time is how to bridge this gap about diagnosing a certain underlying psychological or psychiatric issue, creating an insight in the patient and acceptance in the patient, and finally getting the patient to seek counseling or treatment. We will, of course, largely restrict to PCOS. And of course, there is a huge psychological burden which is associated with PCOS. I think Sejal has beautifully covered practically all aspects of PCOS. I'm going to restrict to the psychological challenges that we see with in dermatology practice, especially. Of course, acne, which could be cystic acne, severe grade 4 inflammatory acne, which leaves scars, as we can see in this patient, is very challenging. And terminal coarse hair in females, what we call hirsutism. Acne, largely in PCOS, is a mandibular or a jawline acne, and it is because of hyperandrogenism, which is excess male hormone. Now, of course, we use our usual topical and systemic antibiotics, oral and topical retinoids, and the chemical peels. And we do get the acne in control, but that's not the challenge. The challenge here really is the chronic and the recurrent course of the disease. There's a lot of fluctuations with the hormonal status, several phases or stages in the patient's life, and even the stress levels. Hirsutism is thick terminal coarse hair on the female face in a male-like distribution. So this has a lot of, it has a debilitating effect. I think it plays mentally or psychologically on people because it has a sort of masculinizing effect on the face. Of course, we do control this with anti-androgens and laser hair reduction. But the challenge here again is if the patients are defaulting in their lifestyle modifications a few years later, even if we have successfully treated and lasered, there are a lot of dormant hair follicles which get stimulated again with excess male hormone, and they may come back 4 to 5 years again with more coarse hair. The psychological challenges with these facial issues, I think, are something that are very alarming figures. There's this lovely study conducted by Hazarika et al. About the psychological impact of acne vulgaris. And if you see, about 60% of the patients who are suffering with acne have anxiety issues. About 75% have interpersonal problems. And a lot of negative effect on their social activities like avoidance behaviors in about 68%. They're very conscious about how they look because obviously, fortunately or unfortunately, our face is how the world perceives us. So there's a lot of self-consciousness, low self-esteem in as much as 88% of the patients with acne, which together leads to poor performance, not just for students in school, but even for adults at work. And that was noted to be about 57%. There's also a self-perceived reduction in attractiveness, which has even shown sexual difficulty reported in about 5% patients. Skin signs like acanthosis nigricans, which are thick, dark patches that we see on the nape of the neck, underarms, groins, are largely because of insulin resistance or insulin-like growth factors acting on the skin level. We use retinoids, lightening creams to reduce the thickness and the darkening and chemical peels. But what's really important to understand is that these, especially this, usually improves even with weight loss. And if the patient has significant weight loss, we don't even have to treat it, it gets better. So as a dermatologist, is the weight loss an important issue for me? Yes, it is, because it brings back the patient with acne, with hirsutism, with acanthosis, and all the issues if we do not treat the underlying problem. And I think as a good clinician, we always want to not just treat the symptoms, but identify the cause and reduce or at least eliminate to the best possible the recurrences. So the crux of the pathogenesis here is, of course, insulin resistance, which leads to carbohydrate or sugar cravings and gives rise to this entire metabolic syndrome, which has already been very well covered by Sejal. Now, the psychological challenges of weight loss. Yes, we all tell our patients that you want to diet and you want to exercise. Do they help? Of course, they're going to help. And of course, you're going to need a good nutritionist and you're going to need a good workout program. But with lifestyle diseases, which are lifelong, this is a challenge to keep the patient motivated so that they can persistently follow their routines. The consistency, the compliance is a big challenge. There's this lovely book, if I don't know how many of you have read, called Atomic Habits by James Clear. Which is about, which says that success is not about one massive transformational change in your life. It's about small habits that we form daily. And I think that's exactly where diet and exercise falls, because it's a compounding effect which is going to benefit. So is it that we really need rewiring of the mindset of the patient? Female pattern hair loss, balding is one major issue that we see in PCOS patients. Androgenetic alopecia in females, as it is called more technically. Balding is not restricted to men, and this is something a lot of women don't know. That's why I have used a very early picture here. If you see, there's a widening of the midline or the partition, and this is the first sign, and unfortunately this is missed. Usually by the time women come to us with female pattern hair loss, the case is very advanced, and there's a lot of permanent loss of hair follicles. So the first sign usually is a widening of the midline partition with really not necessarily obvious hair fall. The age of onset for this is also much younger. It may even precede menarche in some cases. The prevalence is extremely high, it's about 40 to 70%. We do address this with nutritional supplementation, minoxidil, which is the mainstay, finasteride. We do a lot of clinical treatments like micro needling or platelet-rich plasma therapy. But this also carries a huge psychological impact because, as we know, hair is the crowning glory. This is, in fact, something that brings women within a lot of despair and a lot of depression sometimes. Maybe it is because they're losing something that they had, or maybe because balding is synonymous with aging. Is it the fear of aging which adds to their problems? PCOS has a huge psychological burden, and two cases I'd like to share which really endorse this is, one was a 28-year-old female, and I've been seeing her for maybe a decade now. She was about 120 kgs, quite overweight. She had a bariatric surgery. She lost about 60 kgs. And she's really a nice, and she works out now for 2 hours a day. And she's a really gorgeous, good-looking girl, I would say. She had a tummy tuck surgery. She had breast implants. Recently, just last year, she had a little bit of sag and she went back to have a repair surgery or a mastopexy. She had an arm lift surgery. Now, since I've known her for years, she does often ask me whether she should, and I always say, not necessary, you don't need it. But the point is, it doesn't work. So are we dealing with body dysmorphic disorder? If I look up the figures, it's a whopping 49.6%. prevalence of body dysmorphic disorder in patients with polycystic ovarian syndrome. That is actually 1 in every 2 patients. The second was a patient I saw very recently, again, a very charming 24-year-old female. And she had been battling with weight gain, acne, and all her hair issues for about 7-8 years. She had some very bad experiences with some doctors, which I think is important to stress here, that we also have to be very sensitive. It may not be our field, but we sometimes negatively impact the patient. For certain happen to say that there's no way that you're going to lose so much weight, and I think you need to do a bariatric surgery. Fortunately, that worked in a positive manner for her, because she took to it saying that I'm going to do this, and she actually lost 15 kgs in 1 year. Unfortunately, she got diagnosed with hidradenitis suppurativa, which is a very painful, debilitating disease. And we see recurrent painful abscesses, cysts, and sinuses in the axilla, maybe in the breast or the groins, and the association with PCOS is about 9%. Now, when this hit her, I mean, it's really heartbreaking sometimes, because every time she visits, she cries. This was like a negative feedback for her, because this was another new diagnosis of a chronic disease. And what happens is she has now given up on diet and exercise, and is really not in a very good place mentally. So if we see, we may look at the disease, me as a dermatologist or someone as a gynecologist, but we do not realize the impact that is really happening on the person or the patient as a whole. We do also see a lot of PCOS patients approach us for aesthetic dermatology consultations, but I think the patient profile is slightly different from other people who do approach us. They do have this underlying feeling of they're not good enough, or they're lacking in self-love, this low self-esteem. Sometimes they want to stay good-looking enough for their husbands. So there's that insecurity, that need for validation, or their boyfriend likes their lips in a certain way, and that's why they want to do a lip filler. So I strongly discourage, but having said that, there is a lot of this prevalence there. There are studies which have shown the psychosocial impact. Once a study had shown a very high scores of somatization, anxiety, depression, hostility in patients of PCOS. So skin, I believe strongly, is a mirror to the body. What I may just see are the dermatological findings, but really it may just be the tip of the iceberg. There's endocrinology in PCOS, especially gynecology, metabolic syndrome, psychological issues, and psychiatric disorders. And like they say, what your mind does not know, your eyes do not see. So I think it's very important to be updated and integrate all this and help the patients to reach out. So how do I bridge this gap now for my patients from diagnosing and getting them help? Of course, it took me years to realize that I think it's important we remove the shame and guilt that is association with a particular diagnosis. Of course, I don't discuss it at the first consultation. Open up communication, try to build trust, humanize, normalize the experience, and then gently then explore their willingness to seek professional help to be able to tackle the situation in a better manner. So in short, counseling, and yes, I think it does work a lot of times. But this for me as a doctor, because I deal with psychocutaneous disorders, has been a journey on its own, has led me to explore and read in depth about defense mechanisms, how to break them that patients put up. Are they carrying a lot of file wounds? Is that leading to defective attachment? So be it acne expiry, trichotillomania, neurotic excoriations, what is the underlying thing that they have internalized? I can see the narcissism and codependency in couples in myopathy. Are they generational trauma that they're carrying, to the point I even did do a cognitive behavioral therapy online course just to hopefully enable me to bridge this gap for my patients. And hypnotherapy is something I would love to hear from you all. I mean, is it really possible to rewire the subconscious mind so we can break these painful patterns for our patients? So it has been a journey for me to be able to get my patients to take that first step. But I think if it's the first step in the right direction, it's worth it. And it will always be a journey for the patient. So skin, indeed, I think, is a mirror to your body. And we are sometimes just the first point of contact as dermatologists for a lot of underlying issues. So thank you very much.
Thank you, Dr. Sama. Fantastic presentation. Actually, I learned a lot.
Thank you.
And skin is the mirror, of course, and the way you feel comes out, doesn't it? So basically, it's very nice to learn that you're so psychologically minded. Of course, must be something to do with our Rukshida, because she affects everybody.
Sure.
Yes. And it helps a lot because patients are very, there is a lot of stigma associated with psychiatric or a psychological kind of referral. And it's good that you do a pre-counseling before sending the patient to a psychiatrist or psychologist, which is very much needed in case of PCOS. So then to learn more about the mental health bit with PCOS, I would ask Dr. Rukshida Saida to take over, please.
Thank you so much, Dr. Sarmishta. Following in the footsteps of Sejal and, okay, sorry. Hang on a sec. I have no idea what I'm doing. Wait. Somehow I got muted and yeah. Right. Good evening, everyone. Thank you so much at the outset. Thank you, Avinash. Thank you, Bombay Psychiatry Society. Thank you, Hina and Sarmishta, my lovely chairs. And like I was saying, that following in the footsteps of both Dr. Sejal and Dr. Sama is a daunting task for anyone, as you can see right now. So I get extra brownie points for bravery because I showed up. I would acknowledge Dr. Shashi Rai in the audience. Ma'am has always been very, very supportive of all of us. And she happens to be the chairperson of the Women's Mental Health Committee of the Indian Association of Private Psychiatry, and women's psychiatry in India wouldn't be, as at the forefront as much as we have today without her support and so many of our stalwarts like her. So thank you so much for having us today. Just like my meme suggests, my GIF suggests today, I talk a lot, especially when it comes to mental health. So I'm going to request the chair, once my 12 minutes are up, please just give me a heads up. That way I know that I need to really, really wrap it up. It is a very interesting topic in terms of PCOD, because we do see a lot of any clinician, any paramedical staff who does see women, we are seeing PCOD, isn't it? And what I always like to explain, the way I like to explain to people, whether they're patients, whether they're family, whether they're my nursing staff and everything, that when you think of PCOD, think of it as a triangle, where in one aspect there is reproductive elements, the other aspect there is mental health element, and the third aspect is again with metabolic as well as the dermatology. The reason that Sejal and Sama and we work together so much is again because we do see either the patient will first land up with me or with her or with with Sejal or with Sama, because those are the most commonest kind of presentations that we do see, and that's usually a lot of the times they get diagnosed with us, isn't it? What we don't realize is really the close association of mental health from a neurobiological, neuropsychiatric underpinnings. We do tend to talk about the psychosocial impact of PCOD as far as the diagnosis is concerned, as far as the lifestyle is concerned, as far as even the treatment is concerned. But we don't realize that, it is kind of like a two-way highway in terms of the reproductive and the dermatological aspects of PCOD or metabolic aspects of PCOD and the mental health aspects of the PCOD. So as we go along, I'll try and be a little bit more lucid and clear about it. We know that it's a huge impact, and it creates there are a lot of economic consequences, not just psychosocial consequences and health consequences and life consequences. Whether you're talking about PCOD from a young woman to a perimenopausal woman, isn't it? We know that again, the way we keep on, we are talking about it, that the HPA axis abnormalities, we know that, and that also triggers the inflammatory process, which is one of the main reasons or factors associated with depression and anxiety as well. We also know that, even in a very simplistic point of view, when we look at it, then we require estrogen for attention, memory, fine motor, mood, attention, cognition. So when we are talking about requiring presence of of certain neurotransmitters and hormones for the normal development of our brain, of course, we are then going to, it's just going to make more common sense that is going to impact, psychiatric disorders as well as psychological well-being and health. So there are a lot of numerous studies, especially over the last couple of decades, because before that, women's health in itself was not as deeply studied as thankfully it is nowadays, with more gender equality. So we understand the psychosocial aspects of it, the body satisfaction, the sexual relationships and kind of relational issues that come up because of it, the overall quality of life. And we know that the psychiatric disorders are more that there's increased prevalence and incidences of common mental illnesses like depression and anxiety with women with PCOD. When we are looking at quality of life, and that's one of the reasons I put up this picture of myths of psychiatry, PCOD, because we generally do tend to think about it in young girls or in women with reproductive age groups where sexuality might matter more or infertility might matter more. But we are now again kind of realizing that sexuality, quality of life, all of that matters throughout the lifespan, and especially perimenopausal also is a very, very important, significant period of our time. And PCOD, again, like, in a similar, in some cases like bipolar, can wax and wane and come and go. So the symptomatology might be different over a lifespan. And yes, the most substantial, the factors that most impact the quality of life does happen to be obesity, as well as the dermatological side effects that we see because of PCOD. Again, like I said, the body dissatisfaction, weight, body image disturbances. When we see that, when we have the negative perception of PCO, people with PCOD with their own body image, dissatisfaction, again, self-consciousness, they feel less feminine. And that's again something that kind of does get highlighted quite often. They feel less sexually attractive. So naturally that impacts their social behavior itself also, isn't it? And when it's impacting that, we also understand that it may impact their life choices in terms of who their, intimate partner choices, marriage choices, and all of that. And so that's definitely comes in their way of even adapting to normal lives and how they react to normal life situations or changes in their situations. We know, again, like I said, the loss of femininity, obesity, these are the primary reasons that for psychosocial distress, impairment in functioning, as well as lowering of quality of life. So how we understand that stress affects the HPA axis and the immune function, as well as the peripheral and central dysregulation of opioid system. And we know that psychological stress can also impact the carbohydrate metabolism, which is, and that, like, when we talk about the pathophysiology, psychopathology of PCOD and mental health, when we're talking about obesity, we're also trying to understand why is obesity so interlinked with PCOD, and why people with PCOD and increased stress levels, and how that may again increase obesity and then again increase the PCOD, isn't it? And we know from a lot of research recently that when we are looking at women with PCOD, they definitely have a significant level of higher stress levels than those people without PCOD. We also know that the psychological patterns that the cognitive patterns that we notice in women with PCOD has a lot of helplessness and self-blame, and and which also kind of gets then impacts their behavior. And so if they find it a little bit more challenging in terms of how to do problem solving, how to focus on a problem solving, and that definitely leads to a lot of interpersonal issues, a lot of fights and disagreements. We do know now that also that cognition, which is a huge part of our daily functioning, which is, it has so it's so important for us in terms of our psychological well-being, but at the same time is such a significant factor in depression and anxiety, is definitely impacted in women with PCOD. we know that women with PCOD may need additional neural resources during a working memory task compared with women without PCOD. We also know that motivation is a big part of cognition, and we understand when we are looking at women with PCOD and we see that, oh, but we've just described the lifestyle changes, and just described you need to be the lifestyle has to be like a healthy lifestyle which is sustainable. Why is it that these people are finding it so challenging? It's not just a psychological aspect of feeling helplessness and blaming themselves, but it's also a definite neuropsychiatric reason that the motivation aspect of in their brain functioning is a little lacking. So it's when we are going ahead and prescribing lifestyle changes and sustainable lifestyles for women with PCOD, we might look at it a little bit more empathetically, that it's going to be more challenging for women with PCOD to have that sustainable lifestyle than in other people, whether that's men and women without PCOD. So on one hand, we know that, okay, this is definitely what is required in terms of treatment of PCOD, but again, because of the very nature of the illness, it is difficult for them to maintain that. And as psychiatrists and psychologists, we know that so well, isn't it? We know that to get out of depression, you do this, to do CBT, but to do CBT, you have to be a little, get out of depression first. It's just so sounds familiar to us, isn't it? So also when we're talking about, parents will come and say, the mothers will come and sit and put the child and young person in front of us that, oh, she's going to eat so much, how's she going to get married? So apart from the person themselves feeling and struggling with this idea of loss of femininity, lack of self-acceptance, and expecting only negative kind of responses from other people, the parents are also not really very supportive, isn't it? Because I tell her not to eat and she's eating. So we now understand that binge eating is very closely again related to PCOD. So we see women with PCOD have more binge eating patterns, and we have again neuropsychiatric evidence for that. That we understand why there is more binge eating with people with PCOD. So again, a little bit of empathy in that sense is something that we all need to generate. And only if we understand these things, I think we can kind of translate into normal, regular terms for the families and for the patients themselves. So then that is, again, that improves the outcome of the treatment, isn't it? So when we, again, just like my slide suggests, though I apologize because for the busy slide, but if I've also tried to keep the reference of the study that I'm quoting here, and of course, if anybody wants the entire article, please feel free to get in touch with me later, and I'm happy to share. When going ahead, when we also see that, okay, healthy lifestyle, sleep hygiene, sleep, regular sleep routines are so important, but we also know that because of PCOD, it impacts their sleep cycle, the quality of sleep, the architecture of sleep, and again, the sustainability of a healthy sleep pattern is a challenge for people with PCOD. We also know that there is increased or incidences of sleep apnea, especially when we are talking about already a patient with PCOD with diagnosed psychiatric conditions and taking certain medications. In those cases, the risk of sleep apnea, the incidence of sleep apnea is higher, and the diurnal fluctuations of the serum melatonin levels in PCOS patients, the influencing, like I said, the quality of sleep, the architecture of sleep is all again a little bit more challenging for people, women with PCOD. When we are talking about sexual health, there's definitely a lot of evidence to highlight that it's not just the psychosocial aspects of it, the low self-esteem, the low self-confidence, but there's also definite lack of libido that we have seen, and there's also orgasmic dysfunctions that we see in women with PCOD. And again, so So we need to kind of always ask about the sexual health as well, especially to women, because so don't get scared and just go ahead and ask about their sexual activity. I know Dr. Sejal is very good about that, and I know Dr. Sama is also very particular and meticulous about doing a very detailed intake, and because it's important, because these are again important aspects, not only in terms of our target symptoms, but also in terms of functionality, isn't it? And we as psychiatrists and psychologists, that's what our ambition is, not just symptom reduction, but complete functionality. When we're talking about people with psychosis, especially bipolar mood disorders or schizophrenia, I think all of us have come across these young people, young women, where we are suspecting, oh, is this borderline personality disorder? Oh, is this bipolar mood disorder? And when we know that, okay, yeah, very often they also have PCOD. So again, it becomes kind of like the chicken first or the egg first situation. Do women with PCOD, are they more prone to having bipolar and borderline disorders, or women with bipolar and borderline disorders with or without treatment, are they more prone for having to having PCOD? Is the treatment of bipolar disorder, is that triggering PCOD, or because they already have pre-existing, whether that's subclinical or clinical PCOD, does that increase the requirement of mood disorders? So again, like I said, if it helps, if we think about it from a triangular point of view, that if we are looking at PCOD, we are also looking at, if you're looking at a psychiatric illness and we're looking at a PCOD diagnosis, we could treat our patients better. We could approach it from a more personalized medication and personalized treatment plan a little better. And definitely one size doesn't fit all, pun not intended in this case. So when we are talking about challenges of treatment of women with who happen to have a comorbid disorder like PCOD and a psychotic disorder, again, choosing the antipsychotic, choosing the mood stabilizer, choosing even the SSRI for a depressive or anxiety disorder can be very challenging, because the molecule is going to react and impact the body differently in women with PCOD than without PCOD. So again, we want to, but there is still paucity of data. So, but from what we know, that yes, a woman with PCOD with already may or may not, have an issue with obesity, we tend to not prescribe olanzapine. That's not our go-to antipsychotic for a number of reasons, including not just increasing obesity or insulin hyperglycemia, but also because it has a negative impact on the gut microbiome. When we talk about, recently 2020 and 2021, we had these amazing 3 big studies that we came across, first from Sweden, then from China, and then from Finland. Because thankfully their registries are much better maintained, so epidemiological data is so much more easier for them to contain. So over a number of decades, 3 decades almost, they collected data on women with PCOD. And what we saw was that, the PCOD and psychiatric disorders, there was definitely comorbidity and heritability factors involved. And with we know that women with PCOD had a 50% increase chances of having any kind of psychiatric disorders. And of course, common mental health disorders like depression and anxiety were more common. We also saw that, people with PCOD had a higher chance of having children with neurodevelopmental disorders and neurodevelopmental challenges like autism and tics and, other anxiety disorders. So not only just the women with PCOD, but their offsprings were also kind of examined and followed over a number of decades, like I said. And we understand that because of these studies, we also definitely now have more proof of the inheritability of this illness. So definitely we know that there is a common etiology, including genetic factors and, between the PCOD genetic factors and psychiatric disorders. Again, like I said, we've the 3 studies, namely from Sweden, Finland, and China, were they're landmark studies in a way, because the largest cohort that we have, and it kind of underlined and proved the theses and the hypotheses that a lot of us were working with. including my very good friend, Dr. Arshad Hussain, who actually called me earlier in the evening saying, because he has been working on PCOD for a number of years up in Srinagar, and in fact just recently gave a talk on the North Zone IPS conference as well, and he was like, oh, I talked about it, and I was like, yeah, I always quote your study because that's so amazing. And him and his department are also kind of proposing mood and anxiety complex model with PCOD. So that's something that they are working on. We're very excited to see. Of course, with the pandemic, the study has kind of taken a back seat, but we are hoping to see that, see more results. And that's very exciting for all of us in the, not only just the academic, but also the clinical world. Again, there are other kind of studies from India with increased prevalence of anxiety and depression as high as 28% and 11%. Again, interestingly, when we are looking at the origin of PCOD, so not only just like, okay, if my mother has PCOD, there are higher chances of me having PCOD, but also if my mother had PCOD, there are higher chances of me having depression and anxiety. And how is that kind of like coming around? Like, right, like sleep disorders are 1.5 times more increase in prevalence, ADHD is 1.4 times increase in prevalence, intellectual disabilities and ASD is 1.4% times increased prevalence. So how is that happening, and what is the science behind it? Is so it's essentially during the perinatal, the antenatal, during the pregnancy, there is increased exposure to androgens in women with PCOD, and that's probably why we are seeing all of this kind of increased prevalences in offsprings of women with PCOD, as well as like I said, the inheritability of that. So just a recent published article in this journal was amazing insights, and they did a lot. Like, I would suggest a lot of us go back home and read that article. I found it fascinating. So in conclusion, when we are looking at people, we're looking at people, we're not looking at disorders. So nothing beats a detailed history taking in terms of what are possibly the diagnosed but undiagnosed conditions a patient might have, whether the person is walking into a dermatologist or gynecologist or a psychiatrist clinic, because we know that if we are looking at a woman with, depression, anxiety, or query, borderline query, bipolar, rule out PCOD. Always keep an eye on the PCOD profile. Again, it could be subclinical, it could be maintained, but that's going to impact your treatment plan, and it should impact your treatment plan. Women first approaching a dermatologist or gynecologist or even a general physician should and has, when we are suspecting PCOD, always spend a little extra time and talk about the importance of mental health, talk about screen them for at least depression and anxiety, if nothing else. Sharing a PHQ-9 with your colleagues who from non-psychiatry backgrounds is one of the simplest things that you can do to improve the quality of life with early diagnosis, with the aid of early diagnosis. So please go ahead. It's just PHQ-9, which is very, very easy in terms of at least looking for depression. And when we know that even when we are looking for depressive symptoms, a lot of times people will come up and say that, no, I don't have these symptoms, but you know what, now that I think about it, I don't get low, but I do get anxious. So it's such an easy conversation starter. So, I think if you speak to even just a couple of your other colleagues from other faculties, that would go a long way. Definitely a multi-centric, a liaison approach in treatment of PCOD is one of the best outcomes. Definitely, when we're looking at depression and anxiety, a combination of pharmacology as well as CBT, because we understand CBT focuses so much on psychoeducational and everyday life goals, and so the combination of SSR psychopharmacology plus psychotherapy is definitely going to give you a better outcome. And one of the most crucial aspects of PCOD is lifestyle intervention, which is challenging for people with PCOD. So yeah, some amount of empathy and support is definitely called for. Thank you very much for giving me a patient listening. I know I may have created more questions than given you more explanations, so I apologize for that, but I not really, because that might make you go back home and read. Again, if anybody requires any reading material or any of the articles that I may have quoted here, please feel free to get in touch with me. That's my personal email address. You can DM me on Insta. That's, and like, just like the slide suggests, that's all, folks. And over to Dr. Hina and Dr. Sharmishta. Thank you so much.
Thank you, Ruchita. I think that was excellent. I think you covered all aspects. And I think what something even our PGs would probably find very helpful was you mentioned about the studies and all. And I think I would definitely encourage them to get in touch with you and, you know, get those articles and so that they can read. Yes, Sharmishta ma'am, you wanted to say something, and after which I'll take the question and answers.
You take the question, Nina. I
Okay.
just wanted to say excellent presentation, Rukshita, and you've been flowed with a lot of excellent presentation in the chat box as well. As you can see, a lot of juniors have said, and I'm sure they're going to contact you for more material. I think a few things that you rightly kind of said, that it's a completely cognitive and a functional kind of presentation which we see. The patients which we see, you know, there are young people who are pretty intelligent, but when it comes to PCOS and weight loss, somehow there's a denial and it's very difficult to get them to do it. So, you know, it's very challenging. It's challenging for Sejal, for Sama, for Rukshida, but we got to do it. And this is the best start. So yes, Hina, let's talk about it.
Yeah, as Sharmishta ma'am said, I think the entire inbox is flooded with, it has been an excellent presentation. Yes, so I'm going to take the first question, and I think this is for you, Dr. Sejal. Which are the safer OCPs for PCOS, as many report mood symptoms and have clinical depression after starting OCPs, and some even with POP?
Absolutely. I think POP probably would not be my go-to OC pill for PCOS because we do see a lot of depression in these patients. I think of the other oral contraceptive pills available, the generation 3 and 4 OC pills using drospirenone are very good. We see less mental mood swings with them. But for patients who have primarily hyperandrogenism, whether it is clinical or biochemical, I think sticking to the oral contraceptive pills which contain cyproterone acetate is really going to help us, because there's one more thing. When the patient's symptoms in terms of acne and hair growth and all improve, she's automatically going to do much, much better with her mental health. But there are times when we need to change the OC pill, but I'm sure we can find something or the other that definitely suits her and doesn't give her the mood swings. There's one thing we do for all our patients during when we prescribe OC pill is we tell them that this could give you this, and if you have an issue, come back because we can change it and give you something that suits you, so that we'll find a solution to this.
Right. Oh yeah, I think that is equally important to have that kind of a dialogue with your patient, that yes, in the event that you do have any symptoms and all, to immediately come and report to you. I think there's another question for you, Sejal, here, which is if the menses are regular, is there still an increased risk of endometrial CA?
Well, no. And I think this is the best part about PCOS, that in case the menses are regular, there is no increased risk of endometrial CA. But usually what I've seen is when the girls are young, the mothers are bothered, they are bothered, and they're not getting their periods on time, and they're willing to take medications. I have seen an absolute change when the woman is 35 plus, she's finished childbearing. Her only thing is, I don't want periods. I'm very, very happy they're not coming. And there we start the changes of endometrial CA. So for them, it's really important that we counsel them that taking the tablets is absolutely harmless, but get your periods on time. And if the periods are regular, your chance of endometrial CA is like the general population.
Okay, all right. This is a question from Dr. Pfizer. Hi, Dr. Pfizer. He said that for poor patients who cannot afford a whole battery of tests, kindly suggest 3 essential cost-effective tests apart from USG. Should we mention specifically ovarian volume while ordering USG abdomen, myoinositol, cost-effective brand?
Okay, so one is that we should definitely mention ovarian volume when we are looking for a sonography for PCOS. So do it during the periods or just the post-period phase, so we can get an antral follicle count. And we must mention ovarian volume because somehow the sonologists are not mentioning it every time. And that gives us a very, very good idea of PCOS. There's one more thing I want to tell that's very important is that we can't keep doing ovarian volume just to diagnose PCOS. We do it once. There are some people who are expect to do a sonography every 6 months. They feel that if my volume has increased, then my PCOS has worsened. It's not true at all. It depends on which part of the cycle you are, and that is what the volume is dependent on. But you should ask for ovarian volume. Now, unfortunately, there's no go-to test for PCOS because it entirely depends on the symptoms that the patient has. One of the tests we do just for diagnosis when we want to clear is AMH. AMH today has a very high value in diagnosis of PCOS apart from the antral follicle count. And I think this is some tests we are doing in all in a value of more than 6 or 7 does suggest PCOS even if the other symptoms are not there. If my patient comes primarily with hyperandrogenism, I'm going to do free testosterone, dihydrotestosterone, maybe an FSH-LH for the diagnosis of PCOS. If the patient primarily is looking really obese, then I will be looking at fasting and postprandial insulin and the insulin resistance index. So I think the test we do depends on what the patient comes to us with usually.
Okay. Right. The next question is by Zeba, who also happens to be somebody who has suffered from PCOD, and that too for a very long time.
Sure.
He mentions that there were many doubts, especially regarding motivation, that got cleared during this presentation. She would also like to know that is there a relationship between PCOD and breathing issues?
So absolutely, Zeba, PCOS is something that never leaves you. Remember, we always have to control it. We've seen girls in the entire gamut of syndrome. The best way to remain on this side is healthy diet and exercising, and that's a very good way to go about. So usually PCOS and breathing issues come in 2 ways. One is that you get sleep apnea, and I think that is primarily associated with obesity and a very high BMI. And that is a time you really need to take cognizance. I've had a couple of patients who actually, like, she was really obese with PCOS and her diaphragm had moved up so much because of obesity. When she got a pneumonia, she had severe breathing problems. We had to admit her in the ICU, young girl. Finally, she got better with bariatric surgery. So these are the 2 ways you can have sleeping disorders with PCOS. And of course, the psychiatric ones, which I think Rukshida will cover much better than me.
Yes, I think the next question is for Rukshida here, which says that is PCOD more associated with eating disorders?
So there's definitely a link between binge eating and PCOD, that, like I suggested earlier. And as far as other eating disorders are concerned, like bulimia, so there we don't have enough evidence to suggest that it's directly connected. Having said that, we do know that the bulimia nervosa, by creating like a hormonal environment, predisposes polycystic ovarian changes. So there is association definitely, but we're not so clear about causation as of right now. But because lifestyle and self-esteem issues and suicidality and self-harm is so high in prevalence with people with PCOD, then yes, we are always kind of looking for eating disorders. And in fact, one of the things that, because we are so happy that people with PCOD are losing weight and all of that, we may actually overlook an eating disorder and be just very happy with the loss of weight. So that's a cautionary a tale that we want to kind of keep in mind. And instead of because you'll see a lot of young girls with anorexia and bulimia which got triggered because after the diagnosis of PCOD and their inability to maintain a healthy lifestyle, because eating well, exercising, sleeping well, especially for a young person or a teenager, is challenging, is so challenging. And then if they don't see the results, then that's again impacts their mood, which again increases their risk of having an eating disorder. So both from a psychosocial point of view as well as from a neuropsychiatric point of view, we definitely want to keep that in mind.
Right. There is also a question, and it's from Zeba again. She wants to know, this is for Dr. Sejal, that for someone who has missed periods for years and has been obese with hypertension, is it safe to take pills?
So usually when a person has hypertension, we avoid giving them the oral contraceptive pills because that could worsen. But one of the best things to do is give them natural progesterone derivatives to get their periods on time, because it is very, very essential to get periods on time. So whenever we feel the pill is not going to work, we put them on natural progesterone derivatives, and they also work very well to regularize your period cycles. But definitely hypertension, OC pill we should avoid.
Are
So
there any more?
as a psychiatrist, I would like to kind of like say that not just lay people, but a lot of psychiatrists are also very wary of OC pills, because that's the tag for apparently all hormonal combinations, isn't it? And we do see side effects of OC pills in some of our patients with depressive illnesses, which is again, like, like I said, those are associations and not really causations in that sense. And I know I've had like this one 17-year-old young girl whose mother is a patient of mine come in sobbing, completely suicidal. And the only thing that happened was 15 days ago, she started on some formulation. At this point, I don't remember what formulation was. And she was very suicidal. The only thing we did was stop the OC pills, and she got better. We didn't have to start any SSRIs or anything of that sort. So those anecdotal cases are definitely going to happen. But, as a psychiatrist, Sejal, if I'm going to be apprehensive about mental health side effects of OC pills or other hormonal treatments, what would your suggestion be?
I feel that we have all a lot of reading up to do. I think the benefits of oral contraceptive pills for PCOS are beyond established, and it is undoubtedly the first line of management, especially when the periods are irregular. A lot of times, even the drugs Dr. Sama and me talked about in terms of hyperandrogenism really do not work as well as the oral contraceptive pill, because it increases SHBG, which decreases the free testosterone level. So all symptoms of PCOS do get better. But undoubtedly, like you're adding, there's a lot of apprehension with the use of oral contraceptive pills. I think what you might be seeing is a little bit of the depression, but what we see is they're just reluctant to take it because they say, no, I'll not get pregnant and I'll put on so much weight and I'll become fat. And it is a symptom of PCOS is what we try to tell them. So there is a lot of antagonization against the OC pill. Like I said, undoubtedly in some people, it is going to lead to mood swings and depression, but it doesn't happen with all the OC pills. So like we tell the patient that come back to us, we'll see which formulation suits you best. You have to do the same thing, is that figure out which formulation suits the patient best. And I'm sure there's something you can find. Very often we change the progesterone part of our oral contraceptive pill for our patients who are having mood swings.
Okay, I think the next question.
One more question now that I'm on a roll.
Yeah. So Rukshita, this one's again for you. So which antidepressant class of choice can we choose for a patient with PCOD with depression?
If you're going to be dealing with a young person who's in the reproductive age group and may or may not, soon have a child or plan a child, we know from a perinatal point of view, sertraline would be the choice of SSRIs in terms of both depression as well as anxiety. But of course, again, we are going to see lot many prescriptions of escitalopram because that is a very effective SSRIs as well. So you want to make sure that, okay, yeah, you're choosing the the molecule as well, with keeping in mind their reproductive and their sexual functioning as well. If you're going to see, so we're going to start an SSRI with a comorbid PCOD, please always ask them for sexual side effects of even at 50 milligram of sertraline, which does impact. And then maybe like a small addition of bupropion or, can like really help. So you might have to kind of keep them at 50 milligram of sertraline and maybe, 150 or even 300 of bupropion for a better impact on the anxiety as well as the sexual health. Paroxetine, though, is a very good molecule, but I do hesitate to start them in younger people who are in, who are married and might really want to start running a child, just because of like I said, perinatal wise, the safety profile is a little bit more challenging than sertraline. Having said that, I know I have young women who are responding only to paroxetine, along with being the childbearing age group and with PCOD. So again, some molecules, if other molecules are not going to work for your patient, then yeah, go with whatever's working and stick with it and try and work around the problem. So those would be my recommendations. As far as again a mood stabilizer is concerned, again, use of divalproex is so much easier for all of us, isn't it? It's so easy. We don't have to worry about lithium-induced hypothyroid or tremors or toxicity. But we do want to again remember that when we are looking at young women with PCOD, divalproex may again add weight and again add hair loss, and definitely not the safest molecule for during the perinatal phase. So those are some of the things that you might want to keep in mind.
The next question is, what are the risks of prenatal exposure to androgen in a male fetus if the mother has PCOD?
So usually, if there is so much hyperandrogenism, it's one of the commonest cause of infertility. And we have seen that a patient who has a high androgen level, by and large, will not conceive it by herself. Only when the androgen levels fall down to give you a good egg quality is when you conceive. So we really do not see much of this, in our pregnant patients because the hyperandrogenism is controlled. But of course, in patients who have slight hyperandrogenism, and particularly when we are stimulating them for infertility, whether we are doing it for an IUI cycle or an IVF cycle, we do give them small doses of steroid in the first 10 days of the cycle. This decreases the androgen levels for the woman and does help her get pregnant.
All right. I think this one is, there is a female, 37 years of age, who's having PCOS, having period on time, is planning pregnancy. What are the chances of her getting pregnant?
Since she's 37 years old, anyway, she falls in the elderly category, and we all know that the egg quality does go down after the age of 35. If she has PCOS with absolutely regular periods, her probably chance of a pregnancy is same as a 37-year-old otherwise would be. But let me tell you one more thing. Obesity, not only with or without PCOS, is an independent factor for pregnancy, particularly at this age. So a lot of times we've seen that if her PCOS is all right in terms that her periods are regular, even if we can manage to convince her and she loses weight, she shall get pregnant much better.
Can I ask a question, please?
I had a question too.
Okay, first me.
Okay, Rukshita, go ahead.
Dr. Sama, I have this young girl. She is on a combination of spironolactone and some formulation of OC pill. Again, it defeats me at this point. And she's been on it for a number of years without medical supervision. Now, her problem is that anytime that she takes away even one of those molecules, and she's going to land up with this huge cyst, not just like that starts as an acne. So that's one aspect of it, that how do you then deal with, because if she wants to get pregnant now that she's married and everything, what do we do? How do we manage it? Because if she has acne, that triggers almost like a PTSD kind of a reaction because of the severity. That was one part of my question. The second part of my question was, a lot of young, parents especially will come to me that, because the hirsutism and the acne is because of PCOD, the hirsutism especially, should I even invest in the laser treatments for the, hair removal, because if it's going to come back again, what is the sense? So what would you suggest? What do I tell my patients?
Yeah, I think that is something we see all the time, because like we know it is a lifestyle issue, right? It is if the disturbance in the hormone levels is really high, it does happen. Once they go off the anti-androgen, they do start seeing the symptoms again. But of course, like Sejal has mentioned several times, if they can get their diet and exercise in place, it does stabilize the hormones to a great level. Having said that, we have to opt for topical treatments which are safer in pregnancy when they're planning, and we can go a little aggressive with topicals, but we have to, there's a washout period for all anti-androgens, and we have to wash it out, and they do have a little, they may have say a 60% control in the acne in pregnancy, but not like a 100%, but we have to make do with that. Coming back to the lasers, yes, we do see a lot of girls who've done 18 and 20 sessions from several centers for laser hair reduction. So again, I think it's really, really important we address the androgenic levels. And sometimes you'll have normal androgen levels in our hormonal profile, but we see what we call cutaneous hyperandrogenism, which means that's an end organ hypersensitivity, and we still want to use anti-androgens, and this I see is missed a lot of times. So sometimes when they come with normal reports and clinically you have hirsutism, you have hyperandrogenism, it may just be cutaneous, we still want to use anti-androgens, and then laser, it takes about 8 to 12 sessions, they do well, but the same concept applies again. That yes, they could be fine for 4 to 5 years, and then if everything goes for a toss, and again they have high levels of high androgenic activity, there are a lot of dormant hair follicles. It's not the laser hair that grows back, but of course there's going to be hirsutism starting all over again.
Can I just add something to this?
Yeah.
I just want to say one thing, that for all our patients, a lot of who go to Sama for laser hair reduction and who have hyperandrogenism, whether it is clinical or biochemical, of course, but even if it is clinical, a lot of times when we put them on the oral contraceptive pill, what I tell them is start the pill and start your laser hair reduction 6 months down later on the pill.
Yes, I think
throughout the laser hair reduction period, and this is a very good way that it works.
I completely agree. You have to first arrest the abnormal hormonal levels. You're not doing unnecessary sessions, right? We do 8 to 12 for another person. We should want to aim to do that much for even a patient with PCOS.
One more question, Dr. Sama. So people, especially because, they're more concerned about the face, and there is some evidence, I correct me if I'm wrong, that with the laser hair reduction process, there's 25% of increase in fine hair growth on the face. And
paradoxical hypertrophy. Yeah.
Right. So and do you think that there is, or are there any research? Is there any research available that there is higher chances of that happening in women with PCOD or without? Or am I completely off the point here?
No, not really. No, of course it's a valid. It's a very valid question. You do see what you call paradoxical hypertrichosis with laser hair reduction. Now, I would like to believe it's a thing of the past, because of course we've used lasers for over a decade now. The fluence matters. It's important to hit high, go high right at the first. Usually sub-threshold fluences, suboptimal fluences is what gives rise to paradoxical hypertrichosis. Second thing, also the choice, and this would be, I think, common to even non-PCOS patients. Secondly, the choice of patient is very important. You cannot laser really fine hair. If you're going to try to laser really fine hair of fuzzy hair, like baby hair, they're best left. Maybe we can do a laser toning or a Q-switch laser to bleach that kind of hair. But there, of course, sometimes you see this paradoxical hypertrichosis. So the choice of patient is correct, and the optimal fluence is used, it can be avoided.
Yeah, I'm going to ask one question, and that's for Dr. Sejal. Do you think that right now we are overdiagnosing PCOD?
Absolutely not.
No, because when you go through old literature, it says that, are we kind of become more zealous in our diagnosis, and that anybody and everybody who does come to you with obesity, with some subfertility problems, you automatically start thinking only on the lines of PCOD? I'm just trying to get from a gynecologic perspective that have you seen that? Is it because we have now become more vigilant than we were earlier? What would you say? Is this something which was always there and it's now become relative? What would be your take on it?
Well, no, I do think that the incidence of PCOS is on the rise, and this is what the statistics and papers from all over the world suggest. In fact, I think the problem of PCOS is the first slide I put up, that we have to diagnose it early, which is in fact not happening, which is why a lot of complications for later on are happening. Undoubtedly, if a patient walks into my clinic who is obese and who is subfertile, yes, PCOS will be the first thing I think about, because it is the commonest cause of something like this. But the diagnosis is really, really important. So I think the entire crux of the matter is diagnosed. In fact, when a patient walks into my clinic, even looking overtly PCOS, what I tell her is that my feeling is that you do have some hormonal issues. It could be polycystic ovarian syndrome. Let us diagnose it first and then talk the second time you come in. And I think not only an ultrasound, but definitely clinical and biochemical markers have to be jotted down. Then only can we put people into the category. So it really bugs me when somebody comes and says, no, like that day I went to the dentist and he told me I have PCOS. And I'm like, really? I'm amazed at the dentist, really, because no tests are done, nothing is done, just on the basis of obesity and maybe a little hair growth, she's been diagnosed as PCOS. But undoubtedly, I think we need to diagnose this more and more. But we need to be clear on what is PCOS for sure. A lot of times, hyperprolactinemia and hypothyroidism by themselves mimic PCOS. So every time, at least those two tests are an absolute must before we say anything.
I think this has been an excellent presentation. I think we have exceeded way past any time. I'm sure Priyanka would agree. And I guess if we continue, we'll probably have more questions. But I think I'm going to now request my co-chair, Sarmishta Madam, to kindly give the closing remarks.
Yes, I think it has been a very stimulating discussion. I myself have learned a lot of revision, a lot of reading needs to be done. And if our gracious speakers could just give one-liners about PCOS, and then we can end the session. Dr. Sejal, if you could start.
I'm a gynecologist, but I'm going to talk from your viewpoint. I think every time the patient who has PCOS walks into my clinic, we actually give her 45 minutes of time. And that's not only the first session, that's even the subsequent session, because a lot of times all they require, apart from the medical therapy, is motivation. And I think it is up to us to really maintain and motivate them. And I think that is the crux of the PCOS management, constant motivation.
Excellent. Motivation is the important word here. Yes, Dr. Soma, if you could.
I think if we talk about a holistic approach, I think definitely PCOS is the disease which you need to see the patient as a whole, because they carry a lot of things with them, and it's not just dermat, it's not just gynae. So I think that is one disease where we have to give time, and it has to be a holistic approach.
And finally, Rukshida.
So, I'm again going to talk, re-emphasize that because of the clear links that we now have in terms of maternal PCOD and offspring psychopathology, also, we need to be more careful with when we are dealing with our women clients and patients, and we want to be more thorough in our not just intake in the histories, but also have like a more personalized treatment plan. So at the end of the day, when we are talking about a positive psychiatry point of view, as well as a preventive psychiatry point of view, I think women, especially in the vulnerable group of PCOD, needs a special attention, just so that we can prevent more psychopathology in the future. So I'm going to again end with my favorite quote that I may be a little controversial, but I always say that there's no health without women's mental health, and there's definitely no mental health without women's mental health. So yeah, that would be my takeaway from the session today. Thank you.
Thank you so much. And that's my favorite one as well. No health without women's mental health. Yes, thank you so much, Dr. Sejal, Dr. Sama, and Rukshida, or dear Rukshida, and for such a stimulating and fantastic discussion. And I thank everyone here, along with my co-chairperson, Dr. Hina Pandit, and thank you, Dr. D'Souza. I think he's lost in all the women scattering, so can't see him. Avinash, are you there?
He's left, ma'am. I think he's left.
Okay.
I think he's cornered.
Okay. So I think we'll end the session. And Dr. Mohandas is here. Yes, Dr. Mohandas, you unmute yourself, please. Sir, if you could, yes, sir. Yes.
No. I just joined. I heard your comments. That's all. And why do I want to talk anything?
No, please. Any statement from you? Yes, absolute pleasure. And any comment from your part is will be.
No, the problem is what is PC? Somebody has already suggested. Is it a PCO or a PCOS or a PCOD? That is the basic thing. I don't want to talk about the definition. I am not going to give a lecture. But for psychiatrists, the confusion is patient who is a bipolar disorder or valproic acid. They say valproate can produce more PC, it can increase. That is a controversial issue. Initially, the ISO-Jarvis group, they have told that it can produce it. But there are other societies, they say it may not. Even unfortunately or fortunately, I also have contributed on valproate induced, I think some years back, 7 or 8 years back. No, I don't have anything to add. Dukshida is there representing, so she will do everything. I just unmuted that thing because you are told that only females. Avinash has left. So I don't consider myself a female for the time being. And regarding PCOD, my wife is better. She is a gynecologist. Okay. She is the Indian Menopausal Society vice president. So she might be knowing, she knows more on PCOS and PCOD. And I don't want to discuss the criteria for this. Different criteria is there. But somebody has already told hyperandrogenism, etc. And whenever you get this type of people, you have to say hyperplatinemia, hypothyroidism have to be excluded. That's a very good suggestion. Because basically, though I am a psychiatrist, I am a clinician because I have worked in cardiology, I have worked in internal medicine, and I'm interested in other areas. Acupuncture, I have got a degree. I have done the course certification of hypnosis. I mean, so I'm interested to hear all these people. My age is, I think I'm getting old.
It was an absolute pleasure to have you here, and sorry if you felt cornered, but I'm so glad that at the end you actually opened up. So thank you so much.
No, I didn't want to show my diagram initially because I don't want to talk or anything. I want to listen because every Friday I am talking, even otherwise. I have got a program on neuroscience program with my friend Madhusudanan. So we are starting from this Friday. So I thought that I will let me join Rukshida also. She's a IAPP secretary, big boss, big lady, you know. She's a superstar. So at least I had to attend.
Thank you so much, sir. We're very honored.
We'll end the program.
Yes, I request Priyanka, if you can officially end the meeting, and if there are any announcements from BPS end.
Thank you so much, Dr. Hina, Dr. Sarmishta. I am really thankful to Dr. Sama and Dr. Sejal to join us here, and Dr. Rukshida, our all-time favorite. We always talk about psychiatry, but great to know about the gynecological and the dermatological angle of PCOD. It's a great insight for everyone. As Hina ma'am said, we've overshot the time like anything, but still we have people who are listening, who are more interested to know about what's happening in it, and too many questions coming in. So on behalf of BPS, I thank you everyone. The next programs, we're going to keep everyone posted. And I'll send an email shortly about the next program we are planning to have. In the meantime, have a good night, have a good weekend. We'll see you next Wednesday with the next program. Thank you so much.
Thank you, everybody.
Thank you.
Bye. Good night.